Okay, so that should be us going live now. So good evening, everybody. Welcome to today's webinar on capacity. So we've got Dr. Abaris Musumi, who works at Ealing Hospital, and Lizzie Evans, who works at Kingston, talking you through self-discharging patients. So over to you, Lizzie.
Sorry, Lizzie, I think you're muted.
Is that better? Can you hear me?
A lot better, thank you.
Lovely, sorry about that. Hi, hi everyone, thank you for joining us and welcome to our webinar on capacity and self-discharge. Just a couple of housekeeping notes before we begin. Make sure you send all of your questions in on the Facebook Live so that we can answer them all at the end. The session is going to be recorded and we'll send out all the link and materials to you providing you're registered, so make sure you're registered at mindthebleed.com/webinar-registration. We'll pop that in the chat as well. We've also got two members of the MDU here to support us today. We've got Dr. Ross and Lazanne, and they'll be giving us a couple of slides at the end and helping us answer the questions. Remember that you need to get your MDU Foundation membership sorted before you start your shadowing. Unless you filled in the foundation application form, your student membership will cease in the summer. So it's essential that you have your indemnity cover. So we'll send out some links now to help you with that. So with no further ado, I'll hand over to Dr. Ab and we will start our first talk on capacity.
Thank you very much, Lizzie. Thank you for that. There's a specific point where we're going to get back together again, but if you want till then, you can turn your camera off and just watch in the background. Okay, so hello again, guys. My name is Ab. I'm one of the F4s working around Ealing Hospital. I've done my F1 and F2 in Brighton, Eastbourne, Hastings. Mainly done a lot of work in surgery, but a little bit in ED and stuff as well. Since F2. Today I'm going to be talking to you guys about capacity and self-discharging. We're not going to get into too much the mental health aspect of self-discharging, and then Dr. Ross is going to pop in and say everything I've said is incorrect and correct me, which is going to be a treat. But let's have a quick chat about the capacity stuff first. I want to start off by actually asking you guys why you guys think that capacity is important. Why would you think capacity is important? And when I asked myself that, I then started imagining a scenario where you wake up in prison. And I want you guys to try and imagine this as well at the same time. You wake up in a prison, and every day masked people come in and they talk over you in a foreign language, and they start performing procedures, prodding you, poking you. None of them tell you what's going on, why you're there. And when you try and leave, the staff guide you back to your bed, they sedate you, or they stop you from leaving. I mean, imagine the powerlessness you must feel, the anguish, the terror of sleeping in an unfamiliar place, having people do things to you and not tell you what they're doing and what's going on. Of course, I'm obviously exaggerating, but I hope you can understand the parallels between this scenario and what multiple elderly patients go through in hospital when they're admitted. Thankfully, we're trained to communicate with our patients and get their consent before procedures, but if we didn't, it's easy to see what kind of a nightmare scenario could occur in hospital, especially as stresses are put onto an already overloaded system. And that's why you need to know about capacity, because it's not just, oh, we want to do what's best for the patient, so let's do this. You're making life-altering decisions on someone else's life. Imagine waking up one day missing a leg and not knowing why. Again, over dramatization, but the fundamentals important. Fundamentals are important. Consent is the bridge that allows the public to trust us to treat them, and consent intrinsically requires capacity. And so that's why today we need to talk about capacity. There you go. That's our link. So for our contents today, we're going to be talking about how we assess it, what happens when a patient lacks capacity, and what happens when they have capacity. So the NHS UK website defines capacity as the ability to use and understand information to make a decision and communicate any decision made. Pretty on the nose for how we actually assess it. If we look at another source, the MDU states capacity is the ability to make a decision or take an action that impacts on a person's life. It indicates that a person is able to make a decision about their own care and treatment. The GMC have released guidance on decision making and consent that goes into capacity. And actually, I think I refer to that later on as well, because it's really useful. It's really accessible information, actually. There's a couple of points I wanted to make about capacity. Number one, it can be lost temporarily or permanently. An example of temporary loss of capacity is when you may have an infection or because you've decreased GCS because of hypovolemia secondary to blood loss in a trauma scenario. And then, if you fix the underlying issue, capacity, the GCS will go up and capacity should return. Secondly, it's situation and time dependent. So if a patient fails in the capacity assessment for a specific procedure, let's say a surgery, it doesn't mean they now lack capacity to decide if they want to go downstairs for a smoke or what they want for dinner. So they may still be able to make those simpler choices. So you need to assess for each decision individually. And each decision needs its own assessment of capacity. Now, the last thing is assume capacity. You assume that anyone you see has capacity, and then you have to assess them to see if that's the case or not. You can't start off by assuming they don't have capacity. It may feel like a shortcut when a patient has dementia in their past medical history, but as we know, dementia is a spectrum. It's a progressive disease. It doesn't mean that they immediately lose all capacity the moment they have any memory issues. So you assume they have capacity, and then you work to see if they don't have it afterwards. Now, how to assess capacity. So you should be able to remember these four tenets of capacity. But before we actually get to the official way of assessing capacity, there are some situations when this full assessment isn't required. So implied consent and verbal consent is something that I use daily. It's like when you examine someone, you do need to explain what you're going to do, but you don't have to sit down, ask them to weigh up the pros and cons of getting their abdomen examined. If you say, I need to examine your tummy in an ED setting, and they pull up their shirt, it kind of indicates that they're giving their consent. Now, you may remember from medical school that capacity is broken down into these four sections. The patient needs to, number one, understand the information relevant to the situation. They don't need to know the exact biochemistry, so it's up to you guys to give them the information, give the information to them in a way they can understand, and also give the information that's relevant to them as well. That includes using an interpreter or writing it down, or however they want to communicate if they can't communicate in the same language that you can, like sign language as well. It's sometimes you have to go down that route. Number two, they need to be able to retain that information. So patients that are unwell may have a lot of difficulty with this step. So that's probably the one that you can kind of jump to when you're assessing capacity, to be able to quickly say they don't have it. We'll go into that in a second. Number three, they have to be able to consider the pros and cons of the decision. You can give them the pros and cons, but they have to be the ones that consider them. And keep in mind that the outcome of their consideration may be different to what sort of outcome you would have had if you considered that information. So they're allowed to basically make choices that don't match yours, as long as they have capacity for it. And they need to be able to communicate that information back to you. Now, that may be non-verbal. I've heard of versions of things that look like Ouija boards, like they have the most common words they use on the sides, and then they have like a list of letters in the middle, and they use this indicator to be able to say what they want to say when they can't actually verbalize because they have like something in their throat or what have you. So, but as long as they can somehow get that information to you, that's good enough. They don't have to verbally say it. Lizzie, are you there?
Yeah, I am. 1 second.
Lizzie, how do you feel about doing a little scenario for us?
I would love to.
Okay, do you want to take it away? I'll be the patient, you go ahead and be the doctor.
Okay, sure. So hello there, my name's Lizzie. I'm one of the doctors on the ward. What's your name?
My name is Ab. Nice to meet you.
Nice to meet you. I've been asked by one of the nurses to come and have a chat with you about some of your medication. She mentioned that you've been having some concerns about it. Is that okay?
Yeah, it's fine, doctor. Have a seat.
Perfect. So I understand, I think the medication you were concerned about is something called a statin, a atorvastatin. Do you know what you're taking that for?
Yeah, I think one of the doctors earlier said it's for bringing down my cholesterol.
Yeah, exactly. And do you know why that's important?
Not really, I'll be honest.
Would you like me to tell you?
Go ahead, please.
Perfect. So high cholesterol has been linked with problems such as blood clots, which can go into different places, such as the heart or the brain. So it can put you at higher risk of things like stroke and heart attacks. And that's why we put you on a statin to try and bring down your cholesterol.
So taking this basically means I don't get a stroke, right?
Not quite. It reduces the chances of you having a stroke or a heart attack, but doesn't completely remove the chance.
So what would the chances be?
Well, I'm glad you've asked that. I've actually got a leaflet here, which can tell you all the information about it. So do have a read.
Thank you very much. From this, I can see that, it does. It's not that much initially, but it adds up over time, huh?
Yeah, exactly.
All right. Well, see, doctor, the thing is, these pills, they give me dizziness and, they give me terrible wind. I really can't bear the side effects. It really does make my life a heck of a lot harder.
Oh, I'm sorry to hear that. But I can see that you have read your leaflet and you understand the benefits of taking the statin, but have considered them against the negatives of having such side effects, such as the terrible, terrible wind. And I think I'm right in saying that you don't want to take the medication.
Correct.
So I tell you what, why don't you finish reading that leaflet and I'll have a chat with our pharmacist and we can kind of come back and reconvene. And if you really don't want to take the statin, perhaps we can find you an alternative or talk about different methods.
Thank you very much. That's very helpful. Thank you, doctor.
You're welcome, Max.
Oh, dude. I wish we were. Thank you, Liz. You can disappear again. I wish we were doing this in real life so you could take a bow. That was beautiful. Thank you so much. Okay. So that was a scenario where a patient had capacity. But let's say the patient has dementia. That's why we have the blue butterflies there. Let's say the patient has dementia. The nurse has informed you that they don't know where they are, they don't remember much of anything, but they need a specific procedure. In that case, as a general tip, what I've done is after the initial introduction and just getting them comfortable, I ask them why they don't want the procedure, because you have to also remember that your reasons for not wanting a procedure might not be the same as theirs. So they'll say why they don't want a procedure. Then what I'll do is I'll list a few reasons why they should have the procedure, i.e. they don't die or what have you. I tell them about the risks if they don't have the procedure, like if they die. And then I then list their reasons for why they don't want it back to them. Okay, so I've given them the pros of having the procedure and the cons that they've given me, the ones they think are important to me. I've given it back to them. And then I ask if they can state any of those reasons why they should or should not have the procedure. They just need to name me one of each. A lot of the time with dementia patients, you should be giving them time to be able to communicate with you. But a lot of the time they actually stumble on that very simple step of being able to recount anything back to you. And that means that obviously they don't have the ability of retaining that information. I can put that example down in the notes, and that'll be my. I can then go through the rest of the steps as well. But that's one way of saying, boom, I'm happy to say that they don't have capacity to make that decision at that point in time. Another important example is when there's an emergency and the patient's unconscious. Obviously, they can't do a lot of the assessment, so they won't have capacity. And you'll have to make a decision. You have to decide if decisions can wait until they regain capacity, or if you have to start treating them normally in the ED. We just start treating. We start fixing the problem. When they lack capacity, you're given two guidances from the GMC. Number one, you have to choose the option that's in the patient's best interest. And generally, this is life prolonging, as doctors are not allowed to make decisions that are inherently made to shorten the patient's life. But you shouldn't be doing this in a bubble of making any decision without consulting their close friends, their family. They don't get the last word, but you should be consulting with them to kind of understand what the patient's wishes would have been if they were able to make that decision there. And then number two is you go for the procedure that's least restrictive. So you don't go to the end point where it's maybe you lop off a limb or what have you. You go for something that is the least restrictive for them. So if they do come back to consciousness, if they do get capacity again, they can make a full decision themselves. If they have capacity, then you need to attempt to work with them to meet their needs. Give them options so they can choose the one that's most in line with their views. Help facilitate their decision making. So you ask them what their worries are, and then you give them options and give them the pros and cons of, because they have capacity, they can weigh it up themselves, they can decide what they want to do. You want to try and the goal of that is you want to try and keep them as safe as possible without putting in a restriction they don't want. Okay. And generally, if they have a capacity, as a junior, if your patient is refusing, let your seniors know that they refuse, because they may want to talk to themselves. In surgery, if a patient was indicating to me they didn't want to have a surgery done, even though the ward round with the bosses they said they did, then I shouldn't just let that sit there. And if I can't explain well enough why they need it, or if they continue to say they don't want it, the bosses need to be informed so that they don't realize that the patient's rescinded their consent just before they try and put the patient to sleep, because that really slows everything down. So let your bosses know early if patients are refusing have capacity. And make sure you document, I'll keep saying this, make sure you document clearly your assessment of their capacity. And that's the end of the capacity stuff. Just as a bit of further reading, so there's 2 websites. Hopefully in the recording it's high def enough that you can actually type these down. Number one, it's the GMC. So I got this link from the Mind the Bleep website when I searched self-discharging. They had this link there. It's really accessible. It's really easy to read. It does cover a broad base of stuff, so there's a lot there. And I think the MDU website was really good at condensing that down. But we have the MDU guys ourselves anyway. We're lucky to have them, so they'll be having a chat with us later on. And I think, Lizzie, that's my QR code for the session. I'll be 20 to 30 seconds if it's okay. I'll be right back.
No problem. Lovely, thank you, Ab, for that one. So just whilst we're switching on to the next slides, if you could just copy this QRS code and have a go at filling in some feedback. If you could be as detailed as possible, just so we can make the next sessions as kind of fitting for you as we can. So good and bad feedback. Remember, we've also got 2 people from the MDU here. We've got Dr. Ross and we've got Lazanne. So any questions for them as well, do let us know. I'm just looking at the Facebook Live. I can't see any questions at all. There's got to be some questions. So make sure you'll write them down as we go. I'll make a note of them and we'll address them at the end.
It's because I'm covering it so extensively, Lizzie. It's all okay.
Talk, excellent. But if there's any comment, there's got to be some questions. Challenge them. Challenge them. Come on.
Oh dear. Thank you, Lizzie. Thank you, Lizzie.
You're welcome.
Okay, I think I'm ready to go for the next one. I do believe we're now doing the self-discharge. Are we not?
Yep.
Okay, give me 30 seconds.
Yeah,
Boom.
And just to remind everybody that if you fill in the feedback, then you also get a certificate of attendance, which is really good for your portfolio. So make sure that you do that.
Oh, perfect. Even better.
Who said that? Where'd that voice come from? Okay, thank you very much for that, Niraj. Okay, so I'm ready for the second one.
Okay.
All right, so I hope you guys had a break, have a little sip of your drinks. Let's get into the second round. So,
Ab, could I just interject for a second?
oh, please do.
So I just ran a quick poll on Facebook. So the question was, which of these is not a component of capacity? And I think you're doing pretty well because almost everybody has got the right answer. So 93% got the right answer. So keep up the good work.
All right, there we go. I've only put 7% of people to sleep. That's good. Let's get some more energy in our voices as well. Let's do this one. This one is where the meat and potatoes of the talk comes in. So this is about self-discharging. You know what? Funnily enough, me and Lizzie, when we met yesterday, just to make sure we were happy with the presentation, we talked about how when we were younger, we were so worried and so worked up when a patient said they were going to self-discharge. But as time's gone on, and you've gotten more comfortable in the hospital environment, you understand that it's part of the process of a patient. You know, they can take their care into their own hands. You don't need to be so concerned about it. And a really big thing is to keep in mind you're taking care of unwell patients, right? Really sick patients that can't choose to leave the hospital because they're not conscious or what have you. So keep in mind your priorities in terms of you're taking care of unwell patients, right? They take unwell patients, you're trying to keep them safe. And as a preface, what I want to say is take your cue from your seniors. In surgery, your patients are generally too unwell to get up and walk out of the ward if they actually have a surgical pathology. And with surgical problems, they end up eventually getting worse. So just make sure that you safety net people and tell them, hey, you know what? I've assessed you. You're safe. The boss has seen you. He says you're safe to go, so it's fine. Let me facilitate your discharge. I'm not endorsing it, but I'll help you. I'll help you keep you safe. But keep in mind, when it does get worse, because we think it'll get worse, you come straight back over here, and we'll take care of you. And that's the best way to keep yourself safe. It's by keeping your patients safe. And you know, but if your bosses are like, a good thing is if your bosses are really helpful and to help you with your time management, they say, hey, you got 3 other patients and they're really unwell. I need you to take care of them. Don't worry about the self-discharging patients at the moment. The nurses will talk to them in the meantime. Take care of the unwell patients right now. Take your cue from your bosses, okay? They have more experience with this than you might do when you start. So the contents of this talk is we'll have the introduction. There are two main steps when a patient's self-discharging, and then there are going to be 3 different kinds of outcomes based on those 2 steps. And we'll go through a little list of what you can do. And there's a lot more stuff on the Mind the Bleep website. I've used that as a little bit of a template, but this should hopefully give you like a 20-minute whistle-stop tour that gives you some more information on it. So step number 1, finding out about the patient. So you get called by the nurse. She's frazzled. She's at the end of her rope. She's saying this patient's threatening to self-discharge. Well, what you want to do, when you get a chance, get down there, read their file. What's their diagnosis? What was the plan for the last couple of days? Specifically, like, were they meant to be for an operation 2 days ago and then canceled at the end of the day after they got starved? And then yesterday they were meant to be for that same operation, starved for the whole day, and they got canceled once again. They got pushed to today, and now they're just at the end of their tether now. Anyone would want to be would be upset at that, you know. Check to see what they're and if there's been any comments on their behavior in the last couple of days as well. It might indicate why they're so jittery, why they want to leave hospital. Ask the nurses what's been going on, because generally the nurses, they're there with the patient all the time. As a doctor, you're not there with them as much, so the nurses have a better read than you do. If you turn up and you know about the patient, it gives the patient a feeling of importance as well, and that's actually quite positive because it starts a positive rapport. The rapport is already positive because you're a doctor, and that's generally thought of as being like a helper and a healer and what have you, and you're not there like a nurse is, so you're not that authority figure that the nurse kind of has to be now and again. Other things to consider: has anyone been there to visit? If they have, could they have made them a bit? Could they have made them agitated, or is it because they haven't been to visit that they are agitated? If there's a possible psych issue, then consider asking the psych team to assist. You definitely need to get the psych team involved if there's any sort of sectioning that's gone on before the patient's under a section. And generally in hospitals, they have a mental health liaison team. They're normally out of hours. They'd be nurse-led. And to be honest, most of these threats of self-discharging are going to happen on the ED floor, or they're going to happen in the evening, because there's stuff going on in the day. Patients feel like they want to stick around, but in the evening, when there's not as much going on, they get a bit more desperate, and they might want to. They feel like they might want to leave and take their health into their own hands. And then the last thing about nurses. So check to see what the nurse thinks the patient feels towards that nurse. The website says to consider taking the nurse along because they're a friendly face. I'd say the other flip coin of that is the nurses are probably the person that's been talking to the patient and kind of deflecting the patient for the last couple of hours. They might be seen as an authority figure. They might be someone that the patient's butted heads with. So keep in mind, maybe having the nurse there might aggravate the patient rather than get them more on your side. Weigh that up, decide whether or not you want to keep that patient there. But if you're worried the patient is dangerous or agitated or could be a physical threat to you, then you want to have someone there, or you want to make sure you're not locked up. You have some sort of escape pathway there. Keep yourself safe. So that was step 1, right? Find out about the patient. Step 2, meet the patient. Simple, right? So you want to figure out why they want to self-discharge, and that's when you start talking to them. Are they trying to get a little high? Are they missing their alcohol? Maybe they're confused or scared in a new environment. If they're demented, they probably won't know that there's actually stuff we can do for those things. For the alcohol and for other substance abuse, there's programs that they could be on. I'm not sure. It's very locale specific in terms of whether or not they can start those programs in hospital. But alcohol, definitely most hospitals will have. You can give them chloride, epoxide, and other stuff to just keep them calm in the meantime. You want to ask them what they want to do when they leave. Like the dangerous one is, do they want to go home to kill themselves? Because that's like a mental health risk, and we're not going to touch mental health stuff too much right now. We're not touching that mental health act. But we're just going to keep pointing that because that is a big part of this as well. Ask them about their home situation, if they have any pets they want to be taken care of at home and they're worried about them, or any kids. And then maybe you can try and decide with them some sort of arrangement where a neighbor or a family member pops in or what have you. At this point, when you're having that chat, that's when you can check for a capacity. And if there's any perceived mental health issues, that goes down the Mental Health Act, which doesn't use capacity intrinsically, but you can use your capacity assessment as part of your decision for whether or not for their mental health. So you can't say, well, they don't have capacity. For the Mental Health Act, capacity, it doesn't really matter too much, but you can use their capacity state when you're describing how they are as part of the mental health assessment. Patient lacks capacity. So the 3 outcomes, right? Let's say the patient lacks capacity. Number 1, escalate it to your seniors. These conversations probably need to be had by a senior. They're complicated. You're telling the patient something they don't want to hear, which is that they're stuck in hospital or they can't leave. Which generally we don't normally do. Normally we're agreeing with patients or we're facilitating their decisions. They'll have more experience with it. They'll be able to nuance it in the right way. Go for the least restrictive option. The website Mind the Bleep offers considering using GP, ambulatory care, other healthcare professionals. The only thing I temper with that is when I was in F1, I was all about, oh, hey, we have ambulatory care. You can come back in then, and then, oh, you need 2 doses for this? Fine, come back in the morning, then come back in the evening. Like, you're making a complex plan in a pathway that is not there, and you're not even going to be the doctor that has to enact that plan. You're making the on-call team have to enact this really complicated plan. So when you're thinking of using the GP, ambulatory care, what have you, run them by a senior. A lot of this is going to be running it by a senior. You're probably going to be the first one they send to have that talk, and you probably do the capacity assessment, but you'll probably be getting input from seniors afterwards via the telephone and what have you. Step number 3, talk to them. If you need to stop them from leaving, try talking to them to calm them down. If they're not responsive, if they're feeling a bit combative as well, call security. It's amazing how their high-vis jackets have a way of just calming patients down. Security is they're limited in what they can do if there aren't the proper forms in place, like dolls or what have you. They are definitely allowed to just be there, and that does help in some scenarios. Your hospital guidelines may have other teams that you need to contact as well, and if you're keeping them in against their will, or if you're doing any sort of action that's going to be depriving them of their freedom, then you need to fill out something called a DOLS, which is deprivation of liberty safeguards. Lizzie and a couple of my doctor buddies, they had a experience where they had to fill out the 17-page behemoth. I haven't personally. I've been lucky and been in places where the nurses have been filling that out for us. But Lizzie's advice for that was just to make sure that you be brief, but you document specifically why you think they don't have capacity. Number 4, document. Document everything. Document the capacity assessment. Document what they did. Document what you did. List the people involved in the decision making, just to share the burden of this decision around. And number 5, as an F1, you cannot detain patients under the Mental Health Act. Nurses can put in a section 5.4, which is something that they can put in to hold a patient for quite a few hours until they get formally assessed. Or you can ask a senior to come in, they can put in a 5.2, but as an F1, you can't do any of those. All right. Now, what happens when a patient has capacity? Number 1, document. Document how you think they have capacity, include examples of the discussion. Rule number 1 is get everything run by a senior before you just go ahead with whatever plan you consider. Your reg can consider when the consultant should be informed. I know in the website it says consider letting the consultant know. I tell you, if you call the consultant at midnight or 2 a.m. saying, by the way, one of your guys is trying to self-discharge, they're going to have a very interesting demeanor in the morning with you. Consider if period of leave would work. So the website once again offers, hey, have you thought about period of leave? And honestly, in some elderly patients, sure, that could help. The only problem is that there's a couple of different factors. Period of leaves aren't very common. Generally, it's a very senior person that confirms that they can have that, and it's for special occasions. It's rare because if patients are generally unwell enough to warrant a bed in hospital, they're probably too unwell and it's unsafe for them to be at home. So as an F1, you really shouldn't be making the decision that they're okay to be at home for any real period of time. And it does make the logistics of the ward a little bit more difficult in terms of medications and what have you. So you can kind of offer that option up to a boss and then have them make that decision for you. Number 4, get them to sign the paperwork stating they know the risks of self-discharge, including death, and they're happy to take those risks into their own hands. That's just some legal framework thing to do. And state that they're allowed to come back at any time, but they'll probably have to come back in by A&E. Most A&Es do have this rule where if the patient comes back within a day or two, it classes as a failed discharge and it goes straight back to that same department, but there'll just always be a wait for them in A&E. So you're not going to keep their bed for them, just let them know that. And then make the transition as safe as possible. So if they're on antibiotics, consider switching to oral antibiotics as an alternative. Give them a discharge summary. Send that discharge summary to the GP so it's still continuity of care. And you can then ask in that discharge summary if the GP can do a review in a couple of days to make sure the patient's okay. Explain that medications that they want to be taking home with them might take a couple of hours to prepare. And if the patient's saying, I don't want to wait for those, give them the option, hey, come back in a couple of hours, maybe it'll be ready then, or come back tomorrow, maybe it'll be ready then. Last scenario, let's say the patient absconded pre-assessment. So when I was initially writing this, in the trust that I trained in the ED, if a patient left with a cannula, you just straight up had to inform, you had a duty of care to inform the police. Having said that, when I was researching, actually writing these slides, I saw some other trusts that had guidance that said you didn't, in low risk cases, you didn't have to do that. So the thinking behind why you want to inform the police when you have when a patient leaves with a cannula is they can use it to shoot up. You've given them access to a place they can shoot up. They can put all sorts of stuff directly into their veins, which they probably couldn't have, which they maybe couldn't have done if you didn't give them such good access. And you also can't assess the cannula site itself, and they can track infections right into the bloodstream, and that's obviously a big problem. But the guidance that I saw said sometimes maybe district nurses can get involved, or what have you. And always, you can always just call the patient, ask them to come back so you can remove the cannula. So what I'd say with that is read your local guidance. If they don't have it, run it by the bosses. It can just be a quick thing about, hey, boss, the patient just ran out of here and they had a cannula in. Do we need to call the police? And they'll be able to help you make that decision. And it's generally that I'll come into the police in a second, but it's got a couple of factors to it. I'd say as a general rule, for their safety, the cannula needs to be removed. Number 2, you want to track where the patient is. CCTV, there's lots of it in the hospital. Go to security and they'll be able to track them via CCTV to when they left the actual premises. Let security and the site managers know when the patients have absconded, and the site manager can actually start a little bit of a site-wide search for the patient, let them know what the patient looks like and try and hunt them down. And then let the reg know too, just so you've given them a heads up. And then you can start doing the rest of the work while the reg is obviously taking care of other unwell patients while you try and hunt down this patient. Number 3, if seniors decide that police need to be involved, call them and give them the relevant information they need to make a decision themselves as to whether or not they need to find or restrain that person. So generally, they'll be called if the patient is in a real and present danger and the whole team believes they need to come back, and it can't wait until the morning for a GP to be contacted or for a social worker to be contacted to try and get them to facilitate the return. Okay. Police have their own specific way, legislation to allow them to bring people to hospital. One of them is when they bring them to a safe place. I believe under the mental health. Oh, gosh, I think it's like a 3-digit number, 16215. I'm unsure. But they. Thank you, Mr. Ross. That's why we have him here. Anyway, thank you. But yeah, so they have their own laws that allow them to decide when they're allowed to take a person to hospital. You wouldn't want policemen just randomly picking people up and taking them places without some sort of legislation in place. So give them the relevant information they need to make their decision about how they can help your patient. Number 4, like I said, assume capacity. You have to assume they have capacity, but you can check the notes. You can check with the nurses to see if that has information to say whether or not they do or don't have capacity. AMTS of a score of 0, probably they won't be able to retain much information. Have advanced dementia, and they say patients non-verbal or what have you. Maybe they're going to have some difficulty in their capacity assessment, what have you. So you can use that information even though they're not there, and that can at least. And also, you can check the notes for like a mobile phone number and try and contact them and have an informal capacity assessment over the phone. It's better than nothing. Not sure how much it would help in terms of getting them back into the hospital if they don't want to be there, but at least you have something you can actually investigate and document. Because if they're sounding great on the phone, then maybe that kind of stops you in your tracks in terms of how much you can do. In terms of further reading, there's that website from Mind the Bleep. I think that was the best one that I had for this one. It points out a couple other resources as well that we can use. And that is once again the feedback QR code, which means we're at the end of the second presentation. I think I went through that a bit more quickly than normal. Hey Lizzie, how you doing?
Hello, I'm good. Thank you for that. Lovely, another lovely talk. I think it was very succinct. Thank you. It was very good explanations of what to do with patients self-discharging in different capacities. So thank you for that. So we've got 2 excellent questions already on the chat, but I'm sure there's many more pending. And I believe Dr. Ross from our sponsor at the MDU is going to give us a couple of slides, kind of give us a bit more information. Is that right? Hello?
Yeah, sorry.
Ross, you there? Hello, lovely.
Don't worry. Let me just share that screen, and thank you, Abs, for that incredibly enthusiastic talk. I'm not sure I'm going to be able to match that level of energy. I should have taken an energy drink before I started this. Right. Let me. Can you see my slides?
Not yet, sir. You haven't shared your screen.
Okay, there we are. Let's do it now. There. So you should be seeing a slide saying patients taking their own discharge. Now, Abs has gone through some really important information, and in reality, I think he's covered the vast majority of anything I would want to say. All I was intending to do here was to give you a summary from our point of view and how we deal with it, just to give a bit of background. I was a consultant surgeon. I was a consultant neurosurgeon, so I dealt with a lot of patients in whom capacity was an issue. I was a consultant neurosurgeon in England, in Alderhay and in the Walton Centre, and then also in Scotland. So I dealt with all the different jurisdictions, at least within, apart from Northern Ireland. And that's a point that Abs didn't bring up. What Abs was talking about there was very much the English and Welsh approach. Now, the good news is if you're going to Scotland, whilst the jurisdiction is different and the law is different, the effect of the law is really very similar. So what Abs has been saying in that talk, a lot of it is transferable to you working in Scotland. And if you have to work in Northern Ireland, although there isn't capacity legislation fully in place yet in Northern Ireland, again, the common law effect, so that's judge-made law, is very, very similar to what Abs has been discussing. A couple of things I would point out that Abs mentioned that I wanted just to emphasize, and I'm going to take a slightly different tack from Abs. Because I was a consultant, I think that F1s are enormously important in how a team works, okay? And I think if there's a consultant who's ignoring their F1s and not listening to what F1 is saying to them, that's a consultant who may end up with some trouble. So I would never, as a consultant, as a consultant neurosurgeon, be annoyed if an F1 called me. I'd be slightly grumpy at 4 in the morning, but I would appreciate that they'd done that for a good reason. And ultimately, they have the responsibility of care for these patients. So please do remember that if you're not getting anywhere, you can't get through to your registrar, the senior nurses aren't being helpful, the consultant is part of the team, they are on call too, and they will have a wealth of experience that you can tap into. They might wonder why you were calling them first, and they may want to chase up with the middle grades why they ended up answering the phone at 4 in the morning. But it's better to share your worries and your woes and concerns about a patient than find out the next day that you've made a difficult situation worse with what you've done. That was something I want to say. I want to take another thing that Abs said as well about nurses. I think that Abs is right. Sometimes if you've got a patient who's been butting heads with a nurse, having that nurse with you is not helpful. That being said, some senior nurses can be a font of knowledge and information which you would be unwise to ignore. So often they can be incredibly helpful. And even when I was doing consultant ward rounds, I would not infrequently ask the charge nurse, what do you think? Because they are professionals, they do have experience, and although their experience is different, it's still worthwhile. And F1s, and in fact all juniors and consultants too, can learn from nurses. We're all part of the same team. One other point I want to bring up about something that Ab said right at the start about implied consent. He gave the example of I think lifting up your shirt to let somebody examine your belly, and of course that implied consent is something that the GMC recognise. It's in the consent guidance from the GMC, but there are some caveats to that. You need specific consent for certain types of examinations, and you should be aware of cultural sensitivities too. Some women may not be comfortable even with a male doctor being close to them, for instance, doing ophthalmoscopy or examining their knee, not areas that you would imagine normally it would be sensitive areas or potentially intimate areas, but culturally that can be something that people are concerned about. So bear that in mind. And similarly, if you have to go to a proper sensitive area examination, be that a rectal examination or internal examination or gentle examination, then those are situations in which you want to really have talked to the patient, said, is it okay if I do this? And get a clear yes or no. And actually in gynecological examinations, you would normally write down the fact that you'd got consent from the patient before doing the examination. So Abs is right for the vast majority of things, but do think about those specific situations where you might run into problems. So I've drifted off slightly to pick up on some of the things that Abs was talking about in the capacity part. Just coming on to this, patients taking their own discharge, or as the slide was just before I started, patients talking their own discharge, which is obviously not the point, but taking their own discharge, it is something that we see. So let's have a look at the next slide. And I think that this, and Abs and I haven't talked about this in advance, so we're obviously saying from the same hymn sheet, or we're both wrong completely. And I think it's the former rather than the latter. The first question is what I've said. Does the patient have capacity to make the decision that has to be made at this point right now? As he said, capacity is time and decision specific. So for my patients, they may not have capacity to discuss how I would take out a particular brain tumor, but they would have capacity to be able to decide what they wanted to wear that day. That's a sort of silly example, but that defines that there's a difference between certain types of capacity. And ultimately, it's about autonomy. That first story that Abs talked about, when you had a patient who was seeing people talking over her, didn't know what was going on. They were speaking a foreign language, which is what a lot of medicine can sound like to patients. You are denuding that patient of their autonomy as a person. And patients who have capacity are entitled to exercise their autonomy in any way that they see fit as regards their own care. They're allowed to make decisions, and they're allowed to make decisions that appear to be bizarre decisions you would never make. And I think that's often one of the hardest things for juniors to do, is to accept that sometimes people will make bad decisions. And there's so much case law out there backing that up that, you know, just have a look at the consent guidance from the GMC, sorry, the consent guidance to the GMC. It lists some of the relevant case law, which is quite shocking to read, but makes the point that if they have autonomy, if they have capacity, should I say, they are autonomous and they can do what they like. And that's hard, I think, for doctors. The next thing is these patients without capacity. We've kind of talked about that. And when you're dealing with a patient who lacks capacity, and Ab's talked about what that might mean. So in terms of the test, that's a two-stage test. Is there an impairment or disturbance in the function of the person's mind or brain? So that's where you start off. you don't start off by assuming that they're lacking capacity. You ask that question first, and then you go on to the next part of it, which is the impairment or disturbance such that the person lacks capacity to make a particular decision? So that's understanding what they're being asked to talk about, asked to think about, to retain that information, to weigh up the information in their decision making, and communicate that information back to you. The law in Scotland is different, should I say. It's the Adults with Incapacity Act. The effect is almost identical, though. The Adults with Incapacity Act is about 5 years before the Mental Capacity Act, but talks about the same sort of things. If a patient is unable to do any of those things, they lack capacity by definition, and in that circumstance, the treating doctor is entitled to make best interest decision with one caveat, which is that you may have a patient who has a proxy decision maker in place. Okay, Abs didn't mention this, and it is a bit of detail. It's in the Mental Capacity Act, and there are similar provisions in Scotland as well. So in England, you might have somebody who's got a lasting power of attorney, who is a health and welfare attorney, and who's allowed to make decisions for that patient. So in that circumstance, you aren't the decision maker, they are. Okay, as long as their lasting power of attorney is for that particular decision or that healthcare issue. There is another thing there, is if there has been an advanced decision made by a patient as well. I'm not going to go down that line, but there are these patients who have made written advanced decisions to refuse certain treatments in the event of deterioration. So in that circumstance, it's not just their best interests. Best interests, you could almost give a whole talk about best interests itself. It'd be really boring, but you could. And the important thing in best interests, it's not just their medical best interests, it's a broad scope of best interests. So other things, their home life, their family, their social life, all these things factor into best interests. And as I've said, if you're making a best interest decision, you have to, and this is one of the founding principles of Mental Capacity Act, is do the least restrictive thing. So giving an example of that, if you were imagining somebody had a lost capacity because of hypovolemia secondary to bowel obstruction, they were being resuscitated, they had a CT scan, it showed that they had a large bowel tumor, resulting in obstruction. When the patient lacks capacity and there's nobody else to make decisions for them, the sensible thing to do is to do the safest operation right then and there to save their life, to return them to a position where they might be able to make decisions. It wouldn't necessarily be the right time to go and do the most aggressive cancer resection that could be done. You could do something in a staged way to save their life, to get them back to a position where they can make decisions, and then afterwards offer them the option of having a second surgery, as an example, where they go in and do whatever, a total mesorectal excision or whatever it is that the bottom surgeons are doing these days. So that's an example of the least restrictive approach. Abs also mentioned the risk to self or others because of acute mental disorder. And I think he's right not to get into Mental Health Act territory. I think the Mental Health Act is complicated. You should not be having to do that as a junior doctor. You should be involving the mental health team. That's what they're there for. And if somebody has an acute mental health disorder, as in they are actively showing signs of psychosis, they are manic and a risk to themselves, or they are severely depressed and expressing suicidal ideation, those are just examples, you absolutely should be referring that patient on to the mental health team to get their expert input, because they're going to be needed to apply the Mental Health Act anyway, at least most aspects of the Mental Health Act. There is another group of patients, which is, of course, this comes right back to the first thing I said about you being part of a team. Sometimes you're not going to be sure of a patient's capacity. And it's difficult. Sometimes it will be, I get called from A&Es in the middle of the night, not that infrequently, by doctors, and these are registrars and consultants at times, who are not sure about capacity, because it can be quite hard to assess. So don't think for a second that you as an F1 will be right on it and easily able to make the assessments of capacity without any problems. You may not be, and that's okay, because you're part of a team and these things are difficult. So, you know, on top of that, sometimes the risks that are involved can be incredibly serious. And as a junior, you may not be able to fully comprehend what all the risks are, particularly when you're doing specialty surgery or specialty medicine, when your experience is relatively limited. So expressing those risks to a patient can be very difficult if you're, and that's the situation you need to ask somebody else to give you a hand. Sometimes the conditions are so complicated that the next step isn't clear. And you, again, as I've said, you shouldn't be making complicated plans that you yourself are not going to follow through. Gosh, sorry for that talking so quickly there. Right, let's have a look at this one here. Nice short slide. Discussions. So that was to prompt me to remind you again, as Abs had said, to make sure that you wrote down in the medical records the discussion you had, not necessarily verbatim, but the important parts of it that made you reach the decision that you did about the patient's capacity. Also record with whom you discussed your assessment of the patient. Don't just write discussed with Reg, discussed with CT1. Write their name down so they can be contacted about the decision making should there be an issue around it. Make sure again that you've considered the relevant capacity legislation. There will be guidelines in your trust. All of your trusts will have that. If you're in Wales, your health board, Scotland, your health board, Northern Ireland, the hospital trust, they will all have guidance on this. Look at the guidance. It's there for a reason. These are complicated pieces of legislation. You can't be expected to understand everything, but you can be expected to go looking for the information. So, and if you're not sure, ask somebody, please. Better to ask and get the answer right and feel a little bit embarrassed you didn't get it all right first time than make a mess of it. I'll say something else there. Make a mess of it and live to regret that, or worse, the patient not live for you to regret that. Be careful that you've clearly recorded why you think somebody lacks capacity, and as I've said, if somebody has capacity and leaves against advice, safety net, incredibly important. Doctors fall down with this all the time. Make sure you've told the patient what to look out for if things are getting worse. Make sure if they're with somebody and you've got consent, that you tell their family member, if this happens, come back to the hospital. You're not going to share a lot of information. Obviously, you'll not share any information without consent, but you can do that with family members, something that I would do not infrequently. Ideally, make sure you've communicated about the departure, the unexpected departure, with their GP. I think GPs often get a little bit annoyed if they're asked to go and see somebody specifically, so don't try and hive off their follow-up to a busy GP, but at least communicate with the GP, so when they call the GP practice, 2 days later, saying their pain is much worse, the GP knows that they took their own discharge. I think that's all I really wanted to say. In addition, I hope I haven't spoiled things for Abs there, and I hope that makes sense. There are a lot of guidance out there. Do look at your defence organisation, make sure you're a member of one, and do remember the GMC guidance. It's a gold mine of information to be used liberally and referred to liberally. Thanks.
Thanks so much for that talk, Dr. Ross. It was really good that you saved my bacon there by protecting the nurses when I said maybe don't bring them. I'm sure that the nurses over the weekend would tell me exactly what they thought of me over online. Thank you so much.
Lovely. So yeah, thank you, Dr. Ross, for that. That was really helpful. I particularly liked the part where you went into detail about the implied consent. There were certainly some reminders there, which I haven't thought of for a while, so thank you for that. Just before we go on to a couple of questions that have come through, if you can make sure you're all doing your feedback. Firstly, it helps us improve the service, so we can make the lectures come in more suitable for you and change things as we need to. So the more detail you can give us, the better. Secondly, if there's any more questions, do write them at the bottom. This is a safe place, there's no silly questions, so do write them down. You've got, junior doctors here, you've got consultant neurosurgeons, NDU here to support you, so any help we can give you, we're here. Just a point for the feedback again, you get a certificate yourself if you can if you put the feedback in, so it's another tick for the portfolio going forward, and also Ab gets it for his portfolio as well, so he's given up his time to help us today, so that'd be really, we'd be grateful if you could do that. Another reminder, just make sure you've got your indemnity cover before you start your shadowing in the next couple of months. There's links in the chat bit at the bottom about any kind of, I think there's an email for Lizanne who can help you and how you can go forward. So on to the questions. Are you ready, Dr. Ab? We've got 2 excellent questions. I think the first one, I think we've already kind of covered from Dr. Ross's talk just then, but have you got any tips for documenting your capacity assessment or for a patient who is self-discharged? So maybe from Dr. Ab, from a kind of junior point of view, if you have any kind of structure you like to follow when you're documenting.
Well, why don't I give the shoddy answer first, and then Dr. Ross can jump in and actually say all those. Say no, don't do that. But yeah, so basically, I think there in any conversation that you have, there's going to be some things that stick in your head that say that will indicate this person does or does not have capacity. Those quotes, you can put them in. And that'll be really good. The other thing is, if you actually break down the 4 parts of the capacity assessment, understanding, retaining, considering, what have you, and then actually have little quotes saying they said this, therefore not didn't do this. They said that, therefore they can't retain it, or what have you. If you make it obvious for people, then they can follow your reasoning for why you think they didn't have capacity.
Yeah, no, I agree. I think that's fine. I think one of the most important things is that people, particularly juniors in their early jobs, are covering a lot of people and may struggle to keep good records. And what will save your bacon, should things go wrong, are the records that you have kept. So I think everything that Ab said is fine. I don't have any problem with that. Make sure you've dated, timed, and signed it, identified people with whom you've been speaking, and shared the decision making. And this goes all the way through your career. You are not there alone, and you're not expected to doing things by yourself without any input. So share the decision making and write down with whom you shared it.
Lovely, thank you. And another question, I guess, for both of you, if you've got any anecdotal experience, have you had any challenging capacity assessments before? And what were your top tips for these?
Gosh, I have had one that was very challenging, and honestly, I'm not sure if legally everything I did was kosher. There was problems with the nurses said, I'm not sure I'm happy with how we've assessed this, and the consultants were saying no, his assessment's okay, follow through with the plan. Basically, there was this patient that was they had osteomyelitis of the base of the skull, and then with that, the infection had caused them to they'd lost their ability to swallow, and this was going to be happening for a long time. So they had a NG tube inserted, and they kept saying, yes, I will take the NG. And every night they would then take it out again. And it was a horrible experience to put it back in. It was mentally jarring. And we had to start, talking to them about, do they have the capacity to refuse do they have the capacity to request us to remove the NG tube? And it was really difficult to do that. And the problem was they would have capacity to put it in, but then when we tried to assess capacity for us to remove it, they would fail the capacity there, which made it really complicated. And the nurses, because they were stuck by the patient's bedside, they were kind of they didn't know, were they allowed to be depriving them of their ability of removing the NG tube? Because we were talking about like mittens and stuff for them. And honestly, it was, I think, because we all weren't on the same page for that capacity, it probably did affect the patient's care somewhat. Thankfully, we were able to get the patient's family involved as well, and and discuss it with them and say, look, we're really struggling here. I don't think we were smart enough to contact a medical legal team, which we really should have done. But we were, like Dr. Ross said, like, you get really busy and you kind of tunnel vision on something. And that was my difficult experience. And honestly, all I learned from it was that it's just a difficult experience, and you need seniors because they have more power, you feel, than you do. When you have a senior pop in and they say something, you kind of give that some credit, and it makes life easier for you. Anything you want to answer?
I think that's a really a good example, because what you're describing is the situation of potentially fluctuant capacity. Capacity is coming and going. That's really common. The sun goes down, patients lose capacity. We used to see that all the time. It's a very common problem in the dark and things. So it's about maximizing the capacity a patient has, documenting it, sharing written information with them if possible. Ultimately, the problem that you had, it would be the same problem the consultant would have. And if the consultant called me or you called me out saying, well, you need to escalate your consultant, you may need to get a second person involved, somebody who's not directly involved with the case, to give a second opinion on treatment. You may need to make sure the family are on side. And ultimately, if the patient is accepting treatment at one point or most of the time, but refusing at others, but predominantly accepting it, and the family are all on side, and there's an underlying organic disorder, for instance, a meningitis, as I suspect was going on there, or whatever. I think in that circumstance, you might very well just go ahead and treat. And you'd probably be reasonable and able to defend yourself in that situation. But I think it's always situation dependent. Mine, I think, is probably vicarious nowadays. And I think the typical one I get called about is the person who's come into the emergency department with an overdose and doesn't want to be treated. They've turned up in A&E, said, I've taken 40 paracetamol, but I don't want to be treated, which is a typical sort of thing that I get called about. And then, of course, you're coming down to, just as I've said, do they understand why they're, what the risks are of not taking treatment? Do they understand? Are they sober? Are they acutely depressed? Is there a psychiatric illness which has brought them to the brink and made their decision, impaired their capacity, or are they put themselves at risk because of an underlying mental health disorder? These are not easy things to sort out, and they're not easy from FY1, FY2, FY4, CT2 consultant. It involves a whole team, and ultimately you're going to involve other people. So you're going to be calling the psychiatrist and say, I'm not sure what we're doing here. We're short of time. We need some input. This is why we need some input. Can you help us? That's what they're on call for. Call them in, get them to make a decision. They may not like it. That's what they're there for. So your job as FIs is to recognize the problem, not necessarily to sort it. There will be ones that you can't sort, the ones your consultants are struggling with, and that's ultimately what the courts are for. And sometimes the courts, admittedly, not in an overdose of paracetamol, because the courts would take some time to sort things out, but there will be situations you might even involve the courts in treatment. So that was a very long-winded way of saying what I said right at the start, which is you're not alone. Don't try and do it alone. Get some help.
Perfect. Lovely. Thank you very much. And I guess a question I've got, just following on from, you mentioned the Mittens album and going kind of trying to do the path of least resistance. I mean, obviously there'll be guidelines depending on what trust you're on, but do you have a kind of escalation path for if things are getting out of hand, you have a patient who doesn't have capacity, and simple techniques like trying to talk them around, etc., aren't helping. I think as an F1, that was the thing I was really worried about being out on call on my own, having to deal with difficult situations. Have you got any advice for F1s who might be in a similar situation?
Well, in terms of like how you would decide to deprive their liberty, sort of thing?
Yeah, well, do you have a kind of a stepwise ladder that you do of, how you would try and de-escalate a situation like that?
Okay, so I feel like from my experience, when you get to the point where talking and having people around to talk isn't working, at that point, unless there's an obvious risk to self or others, i.e. they're combative and you need to give something to sedate them, then no, I take my lead from my bosses. I didn't bring up the idea of let's use mittens. A senior nurse did, because like I didn't think of it, and I've seen it in some patients, but I didn't think that we would use it in this case. In stuff like pharmacologically sedating patients, like there's so much risk in terms of difficulty in breathing and like the medical risk to that for someone to make that decision, they need to have experience with that, which probably you won't have as an F1, and they need to be able to take that, like take responsibility for that decision, which probably as an F1 you shouldn't be doing. That's my cop out of an answer, which is probably actually what you should be doing as an F1. What do you think, Dr. Ross?
Gosh, now I think it varies. We did use mittens in neurosurgical patients, but those were patients who were definitively lacked capacity to make decisions and were harming themselves by trying to pull it, for instance, intracranial monitors or drains or whatever. It wasn't common out with that, and so what I forgot to say was Abs mentioned the dolls. The deprivation of liberty safeguards as something that you might be involved in. Dolls is a very, very complicated legal process. It's not a straightforward process. And I think that, yes, various doctors may be able to fill in parts of the form, but there are legal requirements for who is able to complete a dolls. And as an F1, you certainly are not going to be that person who's going to be able to do it. It requires a Section 12 approved doctor. It requires various people who need to be involved in it. So just bringing in the dolls into place by yourself is going to be impossible to do. It may be possible with the broader team. That's a cop-out completely of Lizzie's question, which is what are the things to do? As Lizzie would probably know as an anaesthetist, often the underlying problems with acute confusion is to do with organic issues. It's to do with the patient is in the dark. The patients have medications. The patient may be infected. They may have a high temperature. They may be hypoxic. All of those things may impact upon their ability to make decisions. So it's correcting these simple things that you can do as an F1, which will make it much easier for the seniors to go in and correct the more complicated things afterwards that needed to be addressed. Lizzie, I don't know if that addressed the question at all, but that's how I would always want. I'd want to know the ABCs, Ds were approached first before we started bringing out the big guns to try and deal with more complicated matters.
Yeah, absolutely. I think also things I've seen in the past is familiarising kind of the environment so the patient feels a lot more comfortable. So I saw a very good example as an F2 out of hours with an acutely agitated patient. And obviously it was pre-COVID, so the family members were brought in, so the daughter was brought in, and it immediately de-escalated the situation.
That's a good idea, yeah.
So I think trying to think outside the box as well, how you can, is there a nurse that they know from multiple shifts that they get on with? Is there a way that you can change the environment so they're more comfortable, make it more like they're being at home, get them a cup of tea, etc. But as I've said, if they're getting to a point where they're at risk up to themselves and other people, then it's a different story. We need to get seniors involved.
Beautifully brings it back to what Ab said in that first story he presented about the patient not understanding what's going on. That's exactly what's happening to some of these confused patients. They're moved around from bay to a ward or bay to a room. The lights are on, lights are off. They don't know where they are. There's different nurses coming on at 8-hour shifts. They don't know who people are and they're confused. So it's getting them into a well-lit ward. It's getting people around that they know, things around that they know, and the same reassuring faces going in and being kind to them rather than shouting at them for being an annoying person who's used the buzzer for the third time in 15 minutes.
Yeah, absolutely. Lovely. Well, thank you for that. I think I can't see any further questions that have come through. So I think that concludes the webinar this evening. So just to finish off, it's please do the feedback, make sure you get indemnity cover, and always escalate to a senior if there's any doubts, would be my take-home tips from that. Would you agree?
Totally.
Perfect. Niraj, is there anything else we need to add before we disappear?
No, not really. Just thank you very much, everybody. I know that I learned a lot, so I can imagine that hundreds of people who were watching did as well. So thank you very much, Ab and Lizzie. Thank you, Dr. Ross and our partners at the MDU for all of your support. We really do appreciate it. Everyone who's watching, make sure that you fill out the feedback form so we can make the events better for you. And like the Facebook page to be notified about our event next week, which I believe is on referrals and requesting scans. So obviously something that everybody would like to hear about. And I think you get to see Ab as well next week. Is that right?
Yep, I'll be there in the background.
Great. So no more from me. Thank you very much, Loz, as well. Great. Thanks, everyone.
Bye. Thanks
Bye.
for coming, Dr. Ross. Bye-bye now.
Bye-bye.
Bye, thank you.